It's going to be okay.
You'll be fine, inshallah.
In the UK, some 5 million major operations are carried out every year.
Nerves are kicking in now. Good luck, we've got it.
We'll keep you safe, okay?
But some patients' procedures are so complex, only the most skilled surgeons can perform them.
There's adrenaline,
Knife, please.
anxiety,
Lock on, please.
but as soon as you make the incision, everything goes.
Let's focus.
Serving Edinburgh and the surrounding area, NHS Lothian pioneers techniques to treat conditions that few others dare to take on.
You can consider it as a ticking time bomb.
But the cutting edge of modern medicine presents huge challenges.
Every time we operate, there is a risk that things can go wrong.
I'm in difficult territory.
Stop. Don't want to go any deeper than that. I think we'll damage her.
Anything less than perfection
We have a bit of a bleed.
can have grave consequences.
Tube clamp. Tube clamp.
The surgeons
Looks very abnormal, doesn't it?
bear the ultimate responsibility.
We can't offer 100% success in everything that we do.
Take that away from me. Give me this, thanks.
You wouldn't be human if you didn't feel the pressure.
You need to be very quick now. You okay?
This is what really happens behind the closed doors
That's a big chunk of the tumour.
of their operating theatres.
You've done something for this person that can prolong their life.
Beautiful. You can see the pulse.
You're waking up. Everything's gone really well.
It's one of the biggest privileges
I've got good news.
to help people the way we do.
The hospitals of NHS Lothian serve a population of almost 1 million in Edinburgh and beyond. 16 miles west of the capital is St John's Hospital in Livingston, where ear, nose and throat consultant Rohit Gohil and consultant ophthalmic surgeon Rob Peden work on complex cases involving the eye.
I think the human eye is quite an emotive organ. They are so expressive, they define an individual. And so humans tend to hold the eyes in quite high regard.
Eye surgery was something that's really clicked with me. It's a very nice mixture of medicine and surgery, which really appealed to me.
I've known Rob for many years. We used to be trainees together. Having a good working relationship, especially with high-stakes surgery, does need a degree of trust.
Rohit and Rob's next case is a patient with an extreme condition. Her eyes are bulging so far out of their sockets, she could lose her sight.
You can see here the edge of her eye socket on both sides, and her eye is very much further forward than it should be.
It's a very rare complication of an overactive thyroid, a condition known as proptosis, where the immune system attacks the muscles and tissue around the eyes, causing them to swell and bulge.
In the eye socket, it tends to cause tissues to thicken and expand, particularly the muscles and the fat. And with bony walls on all sides of the eye socket, apart from at the front, the only option for the tissue is to push the eye forward.
This patient's eyes are protruding 27 millimeters on the left and 32 millimeters on the right.
Given the severity of this lady's proptosis, she's certainly in a very vulnerable position. The mere fact that they're sitting so far forward, the surface of the eye is so exposed, may cause damage to the ocular surface, and if unmanaged, she could go blind.
Their patient is 55-year-old pharmacy assistant Teresa, who has lived with the condition for almost 14 years.
I've never hidden myself away, although there's been times where I've wanted to.
She lives on the outskirts of Edinburgh, not far from her closest friend, Debbie.
I've not been down the beach in ages. I think it's been about a year since I've been down the beach.
It was in 2010 that Teresa first noticed a change to her eyes.
I woke up and I looked in the mirror and I was like, that's a bit strange. My eye's big. How did that happen? Everything goes through your mind. You think, is it a tumour? Is there something pushing that to make it go out like that? Over the years, the condition just got worse and worse.
You get more nervous now that you're packing?
Oh yeah, because
all
it's making
becoming
it kind
real.
of more real now.
In addition to the physical symptoms, the psychological impact of her appearance has taken its toll.
I was just standing in a queue and there was a little girl. She looked straight at me, cried and went, "I'm scared." It was just a horrible feeling knowing that my looks could scare a child.
To see her going through the pain, she holds it in. She just wants to look normal again.
Prospect of losing my sight is really scary, yeah. It's not something you want to think about, but if I was 10 years down the line and I couldn't see, I think that would be awful.
It's an emotional time. You've waited for so long.
I know, but I didn't think I would be this emotional going for an operation.
We'll use the drill to take out the majority of this.
The only way to reduce the pressure on Teresa's eyes and save her sight is to make her eye sockets bigger, removing bone and tissue, which will give her eyes more space, allowing them to sit in a more natural position. First, Rohit will remove some of Teresa's sinus tissue to access the inner and lower walls of both her eye sockets. He'll carefully remove bone from these walls, taking care not to damage the nerves entering the back of the eye sockets. He will then be able to release the thickened fatty orbital tissue into the space he's created. For stage 2, Rob will drill out bone from the outer wall, just millimeters from Teresa's eyeballs. He must remove as much bone as he can, being careful to avoid entering the brain cavity. Finally, he'll release the remaining thick fatty tissue at the back of each socket, releasing it into the cavities he's created, allowing both eyes to sit further back.
This is one of the largest operations we tend to do around the eye socket. You're always very aware of potential risks, damage to the nervous site, which could lead to loss of vision. It's really important that we avoid entering the brain cavity and cause a fluid leak from there. This can lead to quite severe complications such as low pressure around the brain, infection of the lining of the brain. This is a situation we really want to avoid.
I've been waiting a very long time to get to this point.
Hi there, nice to see you again.
Hi.
Good to see you again.
So what we'll do is we'll talk through two sides of the operation, my side through the nose, and then Mr. Eden's side through the outside.
Yeah. The closer it gets, the more nervous I am.
We'll see you in there. Any last questions you'd like to ask at all?
No.
Fantastic. Well, we're very glad to have you here. See you in there in a while.
Okay. Well, thank you so much.
Across St John's, 13 operating theatres are being prepped. In Theatre 6,
Right.
a team of 14, including 2 surgeons, anaesthetists, scrub nurses, and a neuroimage guidance assistant, are preparing for Teresa's operation.
Okay, so first patient is combined endoscopic lateral orbital wall decompression.
The whole point of today's operation is to decompress the orbits, allow the eyeballs to sit further back within the orbits.
Using image guidance throughout just to help us as well.
Okay, docs. The operation will hopefully save my sight. I'm so nervous and I'm scared. They're going to change my life.
So we'll just start to give you a little bit of oxygen just now. You just take some nice deep breaths.
With a surgery like this, I really don't like any distractions.
Why don't we get the mood lighting on?
How's that?
Perfect, thank you.
You wouldn't be human if you didn't feel the pressure.
Right, are we good to go? Let's do this.
The first stage of the operation is carried out through the nostrils, so Rohit must use an endoscope camera.
Okay, so 15 blade, please. When you work endoscopically, what you're operating on is projected onto a television screen. The benefit of using an endoscope is that it allows you to get good magnification. The area that I'm dissecting is about the size of a small matchbox. And then endoscopic scissors.
To reach the inner and lower walls of Teresa's eye socket, Rohit must first get past the intricate network of sinuses in the nasal cavity.
I want to ensure that I can approach as much of the eye socket through the nose as I possibly can, and that involves opening up the sinuses, especially the sinuses that run between the eyes. The whole point of that is for access.
Maybe I'll just take that lip of bone off. Take away some of that excess tissue.
To create more space, Rohit removes some of Teresa's sinus tissue, which will eventually heal.
Okay. So, at the moment, we're in the left nasal cavity. A bit more bleeding on this side.
The nose and sinuses have a really rich blood supply. That's important in order to maintain the health and integrity of the nose and allow it to do its function. That is until we start operating in the area and upsetting these tissues. Bleeding can obscure the view of the anatomy beyond.
Not good.
For the most complex operations, the difference between success and failure comes down to the finest margins. The Royal Infirmary of Edinburgh is one of the UK's leading centres for the treatment of advanced ovarian cancer. Its foremost expert is consultant gynae-oncologist Nidal Gawi.
Being an oncologist, giving the bad news that you have cancer would be the most challenging part of this job. You don't need more motivation other than the fact that there's a life at risk and you are able to help.
Nidal's next case is a 70-year-old whose cancer is life-threatening.
She had a repeat scan in February, and unfortunately, this showed more of an advanced ovarian cancer picture.
Advanced ovarian cancer begins in the fallopian tubes, but once it reaches the ovaries, it spreads rapidly and can lie undetected. Multiple tumours have now spread throughout his patient's pelvis and abdomen.
There is a multi-organ involvement. There's pelvic disease, rectum disease, and it involves her right diaphragm. We know that with all gynecological cancer, advanced ovarian cancer is the most serious. If left untreated, will certainly cause death.
Okay, now I'm starting to think, it's happening.
Yeah.
Wendy is a retired civil servant from Livingston.
Don't panic, I'm doing enough for two of us.
She's been married to husband Derek for 34 years.
Merci. My husband and I, we love travel. We've done Caribbean cruises, Mexico, love America.
9 months ago, their world fell apart.
My stomach was a problem. I couldn't go to the toilet properly. I went to the doctor and she wasn't happy with me at all, so she sent me off for a biopsy. And that came back cancer. Yeah. Thank you.
As soon as you hear that word, cancer, it's soul-destroying. It was like the end of the world. You have so many things going through your mind.
I've been in disbelief. As far as I'm concerned, nothing's really happening. This doesn't happen to people like me. I'm fine. There's nothing wrong with me. going to be a nice day tomorrow, I think.
Seems that there is some extension towards the spleen, but hopefully we'll be able to preserve the spleen.
Scans show tumours in Wendy's upper, middle and lower abdomen, areas that require different surgical specialties. And so Nadal has recruited 2 colleagues so that their combined expertise will give Wendy the best chance of survival.
The operation is the only way we can get her to the point where there is no remaining disease left.
Joining him will be Chinna Reddy, consultant colorectal surgeon.
Nadal is a very driven and determined person, aggressive in performing these ovarian cancer operations in order to benefit the patients.
Professor Stephen Wigmore is a specialist of the upper abdomen.
I have 3 surgical teams working together. We each bring our own expertise. It's a bit like a football team. You wouldn't want to have a football team that was all full of centre forwards. Nadal is the ringmaster, if you like.
3 teams working together with one purpose: to remove all the advanced ovarian cancer disease in the abdominal cavity.
Wendy's operation will be radical and complex. First, Nadal will assist Stephen to access the diaphragm, the thin muscle between the upper abdomen and chest. Stephen will attempt to strip disease from its lining, taking care not to injure it, as it's vital for breathing. Then Nadal and Chinna will remove a tumour in the pelvis at the top of the vagina. Finally, they will take out Wendy's ovaries and fallopian tubes, where the disease first developed. But their greatest challenge will be finding and removing tumours so small they don't appear on the scans. Leaving disease behind will threaten Wendy's chances of survival.
Some patients will have part of the stomach removed, splenectomy, large amounts of their bowel removed. This surgery might be very, very extensive.
It's 8 a.m. In Theatre 1 at the Royal Infirmary of Edinburgh, Nadal is briefing a 15-strong, multidisciplinary team.
Is everybody here? Can we start?
I don't think we could fit anyone else in, could we? So.
Okay, good. So we are proceeding with cytoreduction.
This initiative to bring different specialisms together to remove every last tumour has more than doubled the overall survival rate of their patients. But success is not guaranteed.
It's a challenge, and I think it's a challenge that we always take, all of us, when we operate for an advanced ovarian cancer. We have this challenge that we have to get to 0, and this is what keeps us motivated before, during the surgery. That's all from us. Anything else? Wonderful. Good. Thank you.
There you are.
Hello. You don't know what's going to happen. Just one step at a time.
I'll just sit you up a little bit more because that made me more comfortable.
For them to say that we can get this, we can fix this, hopefully it will be cleared away completely. They can't guarantee it, but they can do their best.
So you're nice and safe, in good hands.
Happy?
Yep. Knife, please.
Nadal makes a 50-centimetre incision. His and Stephen's painstaking hunt for multiple tumours begins in the upper abdomen.
Although we have all the scans, we never know quite what we're going to find inside the patient.
There's nothing under there. That all looks nice and clean.
You have to use all your senses, sight and touch, when you're looking for cancer. Cancer nodules look whitish in colour, usually raised from the surface. If you put your finger across them, you can actually feel them like grains of rice, quite firm and slightly rough in texture.
The extent of Wendy's cancer quickly becomes apparent. It's more invasive than they anticipated.
This is the gallbladder. With some attachments. Yeah, there's disease here. You can take that.
Seeing the disease, it's evident for us that we need to remove the gallbladder.
Okay, can we take the diaphragm, please? We couldn't see the cancer cells on the gallbladder on the scans, and that is a surprise.
The gallbladder stores bile that helps to digest fat.
The gallbladder isn't really required for an adult human. It's actually safer and easier to remove the whole gallbladder to clear the tumor. There's the gallbladder.
Let's see.
Got another specimen gallbladder.
Now Stephen can access Wendy's diaphragm, where scans show tumour on its lining.
Yeah.
And you see this is really thickened now.
Yeah.
That's the thickening on the CT scan.
Yeah.
That's now clear and evident.
The diaphragm is critical for breathing. As it contracts and expands, the lungs inflate and deflate.
I hope to strip the diaphragm, which means taking off the inner layer of the diaphragm and the tumour, but leave the muscle and the tendons intact.
So it's actually, let's just have a feel.
But they've discovered a problem.
It's full thickness. It will not strip.
I can feel it with my hands, and it's quite obvious that it's invading into the diaphragmatic muscle.
Yes, it's all this that needs to come out.
We need to remove part of the diaphragm. But there are risks because there are major blood vessels and there are nerves. Cutting into these nerves can cause paralysis of the diaphragm, and this will compromise the patient breathing. It's completely full thickness.
In St John's Hospital, Theatre 6.
So we've got the lateral wall over there.
ENT surgeon Rohit is opening up Teresa's sinuses to give him better access to the inner wall of her eye socket.
A little bit more bleedy on this side.
But he needs to control the bleeding in her left sinus.
You can use adrenaline placed on small sponges and apply them to the bleeding areas, and that causes the blood vessels to contract at a very kind of focused area. It is worth anticipating that the longer you take operating, the more bleeding there will be, and the more of an issue that can become.
Why don't we get the image guidance? Make sure that we're on the right track.
When there's a lot of blood in your field, it's always useful to have instruments such as the image guidance, because it confirms to you as a surgeon where it is that you believe you are.
Yeah, confirmed. Okay.
With the sinuses successfully opened up to create enlarged nasal cavities on both sides, Rohit now has space to access the inner wall of Teresa's eye socket, an area fraught with difficulty.
The inner wall is exquisitely thin, and through it, you can actually see a yellow hue, which represents the orbital fat that cushions the contents of the eye socket.
At less than 1 millimeter thick, the inner wall of the eye socket is one of the thinnest bones in the body.
Just by pressing on it, the whole thing moves.
Rohit must remove it without rupturing the fatty layer below.
It's like a water balloon that's fit to bursting, which has got a layer of something else stuck to it, and you're trying to remove that layer without inadvertently damaging the water balloon.
So we just want to lightly fracture the bone, but not upset the tissue beneath. Yeah, right. Looking awfully thin there, so I've just got to be careful.
You really do need to slow down and dissect things even more diligently.
If Rohit tears open the fatty layer below the bone too soon, the contents of the eye socket will herniate out into the nasal cavity, blocking his path and jeopardizing the entire operation.
Very fragile bone coming away.
If I were to damage the inner lining of the eye socket prematurely, it will prevent me from doing a more effective job further back in the nose, as there will be tissue from the eye socket in the way.
As Rohit reaches the last pieces of the inner wall, his delicate task gets even harder.
So the bone was abnormally stuck.
The fatty tissue from the eye socket is stuck to the bone.
I get quite blinkered, and anything else happening around me kind of just fades away because this stage is critical.
Don't really want to go any further back from there because then it becomes optic nerve.
Rohit is operating just millimeters away from the nerve, which sends visual messages to the brain.
Operating this close to somebody's eye can be quite nerve-wracking. I don't think you can ever become complacent just because of how high stakes any mistake could be.
Make the extremely blunt sickle knife. It really is delicate work.
It does take a bit more time using delicate instruments just to tease all that bone away.
Okay, 45 plates, please. Great. I think that did the trick.
I breathe a sigh of relief.
Rohit moves on to the tougher second wall.
Okay, so really thick bone here.
And has now managed to remove all of the necessary bone around Teresa's eye socket, while maintaining a clear line of vision.
Be keen to leave that little root of bone there, otherwise the eye could fall too far in.
Now we want to upset the tissue underneath in order to finally release that pressure.
We're just going to open the content now.
Carefully, Rohit makes a series of shallow incisions through the fibrous outer covering of the orbital fat.
I need to be careful because all the muscle that moves the eye inwards sits very, very close to that surface. If we were to injure it, it can cause issues with double vision.
You see that thing that's starting to want to jump into the nose right away.
As I proceed, more and more of the tissue of the eye socket expands into the space that I've created.
And then as we push on the eye, there, look at that. Nice.
The amount of pressure in the eye socket has gone down, and it is a lot softer to the touch.
And the pressure's well away, look at that.
And you can see the eye starting to sit back as well, so you get that satisfaction of having done the best job you possibly can for a patient.
Fine, let's do the other side.
Whilst Rohit repeats the process on Teresa's left eye,
Can I get the sickle, please?
Rob scrubs in to prepare for the next stage of the operation, removing the third and final wall.
Operating on someone's eye takes some getting used to because it is something that's deeply personal to people. We talk about the eyes being the window to the soul. And so I think to see someone operating on an eye triggers something quite deep within us. Well, let's get underway.
To access the outer wall of the eye socket, Rob makes a 4 centimetre long incision along Teresa's right eyelid crease.
At the back of the outer wall of the eye socket is a thickened area of bone called the trigone. What I'm really looking for here is nice access down that wall so I can really see everything that's happening. And it's really important in cases where you're trying to get as much decompression as possible to remove bone from this area.
To protect the delicate tissue of the eye socket, Rob uses a metal retractor to push Teresa's eye to one side. The bone of the outer wall can be up to 2 centimetres thick. To thin it out and create more space for Wendy's enlarged eye, Rob uses a high-speed drill.
think some people would find what I do quite disconcerting. Using a drill in a confined space like this, where you're surrounded by very important structures, does require a high degree of care and attention. As an eye surgeon, your patient's vision is always foremost in your mind.
To prevent infection, invasive surgeries like Teresa's must take place in an environment which has been meticulously cleaned and sterilised.
14 first.
Yeah. Start at the top and work our way down.
Every evening, a dedicated team of 33 domestics work through the night, deep cleaning every operating theatre across NHS Lothian.
If the theatres were not clean, they wouldn't be able to operate, so everything starts with the cleaning. That is hopefully preventing anyone from catching MRSA, E. coli, Legionnaires.
It is life and death for some people. The smallest bit of bacteria or dirt that gets in the wrong place.
I've worked here for 16 and a half years now. I actually had my little boy in one of the theatres up here, so it was really nice to then come and work here.
When I started, my supervisor at the time says to me, treat the hospital like a member of your family's coming in. And that's the way we've always done it.
Decontamination of surgical areas requires strong disinfectant, 15 times the strength of household bleach, and rigorous cloth management.
With your cloths, you should never double dip. If you're doing your sink, you would do your tap with one cloth, bin it, get another, do the actual outer area, because we are trying to prevent cross-contamination.
Another important nightly routine prevents bacterial build-up in the water system.
We have to run our taps for 5 minutes every night, and that is to prevent Legionnaires. We have log sheets, we have to mark to say that that has been completed in every area that has a tap.
Each of the region's 55 operating theatres takes an hour and a half to deep clean.
There's nothing more I enjoy when there's a floor that's really bad. What it looked like before and after, I love it. It gives me a sense of pride when I come away from a flare and it's, look what I've done. It's a sense of achievement. I've got a disabled stepdaughter and she's spent a lot of time in hospital. When I go to visit her, I'm checking how clean the room is that she's in, because I know what it should be. We take a lot of pride in what we do. It's going home and knowing that we've done a good job, and that's that.
It's mid-morning, and operations are well underway across NHS Lothian's hospitals. In the Royal Infirmary of Edinburgh, in Theatre 1.
Can you just tighten up this retractor? Okay, that's great.
Surgeons Stephen and Nadal have discovered that the tumour on Wendy's diaphragm goes deeper than they'd hoped.
I think this will need resection.
If we don't take away the full thickness of the diaphragm, we'll be leaving quite a large volume of tumour behind. There is no other option for Wendy. Can I put that to you?
To add to the challenge, lying directly behind the diaphragm are Wendy's lungs, which are being controlled by a ventilator.
Her lungs are still going up and down, and they're coming very close to where we're working to try and remove the cancer. Okay, and diastema, please. There's a risk using the electric knife that we use to cut through the diaphragm that we can damage the lung underneath.
If damaged, it could lead to complications affecting Wendy's ability to breathe on her own after surgery.
My assistant's helping me in maintaining tension on the diaphragm to keep it away from the lung. We're watching the lung inflating and deflating and trying to time our movement to cut through tissue when the lung is as far away from you as possible.
Access into the 12 meter. Yeah.
Thank you.
Suction. Just come the other way a second.
Okay.
Diaphragm.
Got a specimen here. Diaphragm.
An 8 by 6 centimetre tumour has been removed, but it means a section of Wendy's diaphragm is now missing.
So we have to start thinking about the repair as soon as the tissue comes out.
Let's take the stitch, please. Okay, thank you.
The diaphragm is a dome-shaped structure, so we can make the dome a bit smaller by joining the edges of the wound together again.
Suction, please.
Although smaller, Wendy's diaphragm will continue to function. But before Stephen can fully close the wound, he must remove any air between Wendy's diaphragm and lungs, or her lungs won't work properly.
We'll put the suction in here.
Yep.
How I do that is to ask the anaesthetist to inflate the lung up fully. So Rachel, could you do a Valsalva? At the same time, I use the suction device to remove air between the lung and the diaphragm.
Thank you, that's great, perfect.
And close the stitch, sealing the diaphragm at the same moment.
That's great, and just normal breathing now, thanks.
When we remove the air, you can see that the dome shape of the diaphragm has reformed and that the diaphragm is moving appropriately and normally as she breathes.
Yeah, thank you.
Okay,
swap.
Looks quite nice.
Yeah, we'll just keep swap for now.
Seeing the diaphragm move like that is really reassuring.
Yeah.
Yeah, good.
Great. Good, wonderful.
I set the scene by clearing all the tumour that I can and then hand over to my colleagues to do the rest.
Okay.
Thank you very much.
Thank you.
A major tumour has been removed from the upper abdomen, but the mission to find potentially dozens of tumours elsewhere has just begun.
So we're just now underneath the stomach.
Attached to the stomach is an apron of tissue called the omentum.
Let me feel this area, if there's any nodularity there. Feeling the omentum and looking at the omentum, we see multiple nodularities. I think we'll just need to remove as much as possible because you can feel nodularity all over this area. So there must be still viable tumor. The omentum is fatty tissue with a very prominent blood supply that would harbor lots of cancer cells to breed and multiply. We remove the omentum to make sure that there is no disease left.
Tumours grow fastest where there is good blood supply. And so, although the omentum has a role in immune function, it must be sacrificed.
So that's the omentum removed.
I've got another specimen here.
Next, the appendix is removed,
So I've got appendix.
along with part of the bowel,
Met scissors, please.
as both had tumours attached.
Cecal deposit.
Colorectal surgeon Chinna is crucial for the next phase of the operation,
Run the table down a bit as well, please. Thank you.
clearing all traces of cancer from Wendy's pelvic area.
Let's have a look. Do you see anything?
They must now locate the 5 centimetre tumour seen on the scan on the top of Wendy's vagina.
The pelvis is a very narrow space deep down where you're operating. In Wendy's case, she's had previous hysterectomy, which would mean that there is more scar tissue in the pelvis. This can make the surgery a bit more technically challenging. Can I have a suction, please, with the tip out?
There. Yeah. That's it. Okay.
So we see a nodule in the pelvis, on top of the vaginal, very close to the rectum and the bladder.
Long debatis.
The margins are very, very close to be able to get the tumor away but not cause any damage. We're talking about millimeters. Every time we operate, there is a risk that things can go wrong.
Just need to be careful of the
Yes,
victim there.
yes, yes. Back up, please.
4 hours into the operation, all Wendy's husband Derek can do is wait.
I can't even say it's been roller coaster because it's really been downhill, not knowing what the outcome might be. There is no option. It's a risk that has to be taken.
In Theatre 6 at St John's Hospital, ophthalmic surgeon Rob is drilling just millimeters away from Teresa's eyeball to enlarge her eye sockets and create a bigger space for her eyes.
We only get one attempt at removing the bone here. It's not going to be possible to access this bone again later. We've got to really make sure that we take as much bone as we safely can in order to give it the best possible result.
Doesn't feel like I'm on bone. Let me know if I'm pinching any tissue there.
Yeah, no, it's looking okay at the moment. It's important when we're using the retractor not to put too much pressure on the eye socket. There's a reflex that can be caused when you're working around the eye called the oculocardiac reflex. There's a loop of nerves that run from the sensory muscles around the eye back to the brainstem and connect down to the heart. Pressure or tension or stretch on tissues of the eye socket, particularly the muscles of the eye socket, can trigger this reflex, which causes the heart to slow, the blood pressure to drop, and can even cause the heart to stop altogether in extreme cases.
Maybe just that little bit anteriorly and inferiorly.
Just need to be a bit cautious with these.
There's also another major risk.
The problem being that behind that is brain, and so it's trying to figure out how far backwards we are. With the scale we're working at, we are dealing with millimeters of bone here between the back of the eye socket and the brain. Movements need to be very small, very controlled.
Right, image guidance probe again, please.
Great, thanks very much. It's very, very useful to have someone experienced like Rohit with a second pair of hands. We have used the image guidance to help reassess as we're going on exactly how far through the bone we've got.
Quite a way back.
The area of trigone bone Rob must remove sits between the red and blue lines highlighted on Teresa's scan.
Well into the trigone.
The area in blue marks the boundary of her brain.
When you're operating around the eye and the eye socket, the difference between success and failure can come down to millimeters, or sometimes even less than millimeters. Make a little bit of that prominence just there. There's a real heightened awareness as you come towards the critical parts of an operation. You see right down to the edge of the floor here. Arguably, we could take a tiny bit from that edge just here with the long drill. We're progressively removing smaller and smaller amounts of bone. Therefore, the benefit from removing more becomes less and less, whereas the risk progressively increases. And we're getting closer and closer to the CSF, which we want to see.
Drill too far, and Rob could puncture the brain cavity, which is full of cerebrospinal fluid, which cushions and protects the brain.
A leak of the fluid that supports the brain and the spine can lead to infection inside the brain or of the lining of the brain. So we're watching very, very closely to ensure there's no escape of any of this fluid during the operation. The further back you go, the higher the risk is of damaging important structures, the narrower your view becomes. You're coming towards the finer point of a cone. I think we're pretty much done with the bone removal on this side, which is round about there.
Rob decides he's removed as much bone as he safely can from Teresa's right eye.
In surgery, it's really important to know when to stop. Sometimes the hardest thing as a surgeon is not operating.
Pupils happy?
Yeah, it's good. Looking good, actually. So let's release the fat. Take a little bit of fat, as much as it'll come.
Rob can now relax Teresa's eyeball into the enlarged socket.
I release the bands within the fat to allow it to move more freely. See the way it's spilling out a lot more now. Pressure is much lower, the socket's much softer and feels much more natural. You can see that now. Sitting nicely back in the socket. Feels nice and soft.
Eyes actually just sat very normally now.
Yeah, so you feel like that's in a pretty anatomical position there, in fact, even with the swelling. Operating on someone's eye is very much a mixture of art and science. You've got to adapt to each person's individual anatomy and how it fits with the rest of their face.
He repeats the process on Teresa's left eye to ensure her eyes look symmetrical.
It's often tempting to do the same amount of surgery on both sides, but if you do, you'll often end up with one eye appearing more prominent than the other. Part of the art of the decompressive surgery is balancing the two eyes as much as possible. There's a degree of asymmetry in most people's faces, but it's something that we are naturally drawn to see.
So take a little bit of that fat, perhaps.
And so it's good for us to try to get the two eyes as close in position to each other as possible.
The pupil's still very happy. Corneal surface is fine.
Got a view from the top there. What do you think?
Looks balanced. Yeah, much better.
Yeah.
Great.
Nothing like it.
And her eyes are actually closed at rest.
Yeah.
Performing an operation like this and getting that visual feedback that the eyes are sitting further back, that the pressure has gone down to the feel is immensely satisfying.
The end of a long operation can be quite physically tiring and also mentally tiring as well. But there is that sense of knowing that this patient's life is going to be better afterwards.
Teresa, that's your surgery finished. You're waking up. Everything's gone really well. Thank you. I'll get this.
After 7 hours in theatre, Teresa will now be taken to recovery.
Okay.
In Theatre 1 at the Royal Infirmary of Edinburgh,
And a debicki as well to me, please.
Thank you.
colorectal surgeon Chinna and gynae-oncologist Nadal are trying to remove a tumour from the top of Wendy's vagina, which is also stuck to her bladder and rectum.
The tumor itself is attached superficially to the rectum in front, but not gone through the rectal wall. So we are able to dissect it away from the rectum without causing damage.
Okay. But it's more challenging to separate the tumour from two other organs, the bladder and the vaginal vault, where the vagina was closed when Wendy had her uterus removed 7 years ago.
After hysterectomy, the bladder will attach itself into the vaginal vault. So we need to dissect the bladder away from the field. Before we can remove the tumor safely. Can I give you this, please?
The 5 centimetre long tumour, seen on the scan, is removed.
Yeah.
But they must be certain nothing else is lurking behind.
That's how we feel. And still feel nodular there. This nodularity might indicate that the disease is invading into the vaginal vault. Babcock, please.
Nadal and Chinna cannot risk leaving any trace of cancer behind, or it will grow again. But removing it has consequences.
There.
At each step, we are weighing up the possibilities of trying to achieve the best by minimizing the damage that we cause to the patient.
This will probably open the vaginal vault.
Opening the vaginal vault could impact the bladder, risking more complications for Wendy.
Ideally, it would be better if we do not open the vaginal vault, but this will allow us to make sure that we have removed all the disease from this area. So we've opened the vaginal vault.
Another tumor is taken out, without the need to remove part of the bladder. With the vaginal vault checked and closed, Nadal and Chinna can focus on where Wendy's cancer first developed.
Okay, we'll just now remove the ovaries. We know that the origin of the cancer started in the area between the ovary and the fallopian tubes.
So we're just taking the tube and the ovary on the right side?
Yes.
The right ovary and fallopian tube are easily removed. So Nadal and Chinna move over to the left.
You see there's tumor there on this ovary clearly. Okay. This one is more stuck to the side wall than the other one.
We find that on the left ovary, the disease is bigger, there is more scar tissue, and this will make the removal of the left ovary more trickier than the right side.
Let's have a look on this side.
The scar tissue surrounding Wendy's left ovary is a consequence of preoperative chemotherapy.
Chemotherapy has two effects. Obviously, it's reducing the size of the cancer, but it also can cause scar tissue. So it is a double-edged sword.
Nadal must painstakingly unpick the left ovary and fallopian tube from the surrounding tissue.
Yeah, okay. Curd mayo, please. The origin of the tumor.
Yeah. That's all clear?
Yeah, it's fine.
The rectum is nice and intact?
Yeah.
So far, as well as part of her diaphragm and bowel, the surgeons have removed 7 of Wendy's organs. But Nadal and the team must be sure they've got every last trace of the cancer, no matter how small.
Any visible cancer, which we call macroscopic disease, we would need to remove it. The survival of the patient depends on getting them to 0 residual disease.
Was there some errors to plasma there, or they?
To be honest, I'm in two minds. I'm not sure is this tumor or not. I'm just trying to make sure. Let's walk the bowel and then we can have a look.
There's a bit, you want to take that off?
Yes, I think you can see there's evidence of previous tumor around this area, and it's nodular, so yes, we should remove it.
The ultimate goal in ovarian cancer surgery is to try and leave no disease behind. We are able to achieve that goal by looking with the naked eye and assessing that we've not left any disease behind. We as a team are aggressive in dealing with the ovarian cancer itself so that the outcomes are better for the patients.
As we remove more disease, this keeps you going. There's a little bit nodularity here in this area. This keeps you more motivated to make sure that there is no residual disease as you promised your patient. That's the whole bowel completely clean. Good. Wonderful. I think we have managed to get to 0.
So when we find that there is no macroscopic tumor left, that gives you a sense of pride and satisfaction that we've done something good here.
You happy, Nadal?
Yes, we are more than happy.
Okay, good. It all looks very good.
Yeah,
very pleased with the outcome here.
When we get to the end of the operation, the most dominant feeling is relief.
Wendy, hello there. Hello, yeah, just waking up after your operation. Everything's absolutely fine.
The fact is that if we remove the disease its entirety, we give her the best chance to fight. And this is what we have done.
"7 weeks on from surgery to reposition her eyes and save her sight, Teresa is enjoying a new lease of life.
It's such a lovely day. I didn't think it was going to be this nice.
The sea is beautiful, isn't it?
The sea is absolutely gorgeous.
Go for the dip.
I didn't bring a swimming costume. I just can't believe how well it's went. I'm smiling now, I'm out, I can walk about without sunglasses on, not feeling judged, whereas before I felt like I was being judged.
I just can't believe the difference in Mum. The girl who I grew up with, she's just back. Her bubbly self and happy. It's just so lovely to see.
Right, I think up here is a nice shot for a wee selfie. Let's see, where's the Cramond Island? There it is. I wouldn't get photos taken if we were out with friends because I'd be so self-conscious of the way my eye looked.
That's better.
That's better, up the way.
Seeing the impact of surgery like this on patients like Teresa is hugely rewarding. It really makes one feel like you're making a difference.
I feel like a different person. If it hadn't been for the surgeons, then I would still be in a shell, still hiding behind sunglasses. It's just been amazing. I just can't thank them enough. That's us. Selfie's done for the day.
Selfie's done for the day.
It's been 4 months since Wendy's major surgery for advanced ovarian cancer, and she has returned to the Royal Infirmary with husband Derek.
Okay, who did that?
Didn't touch it. Didn't touch it.
After the operation, I had another 3 lots of chemo. I was feeling quite sick a lot of the time, but Derek has been his usual rock.
Today they are meeting gynae-oncologist Nadal.
So in general, we're really satisfied with the result. Now, there's no more disease.
Yeah, everything that you had said, that confidence that you gave, it helped so much.
It's a confidence that we've achieved what we set to achieve during surgery and remove everything. We're hopeful that you will not need us anymore, and that would be the best.
Not against the power.
Yes.
Thank you so much.
You're welcome. You're welcome.
The most important thing is that we do have a future, which is absolutely fantastic. We are now looking forward to travelling again and having some fun, which has been missing for a while.
Yeah, I'm gonna.
We'll see you. Great, thank you. Thank you.
I never ever thought that I'd have cancer.
Thanks very much.
You.
Take care, Nadal.
I am very grateful to all of the team because I've got my life back.
It brings me pleasure, satisfaction, and relief to be able to tell them that you're 100% sure that we've removed all the disease and it's worthwhile.
Beautiful day.